Go ahead and get started. Welcome everyone to Geriatric Grand Rounds. Thanks for joining us this morning. Couple of announcements before we get to today's presentation. So next Grand Rounds is going to be October 21st, and that will be our annual pharmacy new drug update. So please join us for that. Journal Club will be next Thursday, the 14th. And our presenters are going to be Dr. Thomas Johnson and Dr. Carrie Hornay. After today's Grand Rounds, you will receive an email with a link to a recording of today's presentation and a copy of the slides. There will also be a link to an online evaluation, so if you could please take a moment to fill that out, that would be very helpful. Please feel free to submit questions in the chat or Q&A boxes during the presentation, and we will get to those at the end. And also just wanted to let everyone know, if you hadn't seen it yet, that we are going to plan to have Grand Rounds just virtually for the foreseeable future. We had tried a quasi in-person, but given the state of things right now, we're just going to be all virtual for the foreseeable future. So I'm very pleased to introduce our speaker this morning, Dr. Karina Drake. Dr. Drake attended medical school at Albany Medical College and then completed her adult psychiatry residency and a geriatric psychiatry fellowship at the University of Michigan. She was on faculty at University of Michigan for several years before we were lucky enough to get her to come to Colorado, and she joined us in the summer of 2020 and has been just a wonderful resource to us in the seniors clinic, I can say for sure. So she's going to talk to us today about treatment of late life depression. So welcome, Dr. Drake.
Thank you so much for that introduction. And I also do want to start by saying how much I've enjoyed working with the seniors clinic. You guys have really been wonderful collaborators, as Dr. Pliss and I have been working to grow geriatric psychiatry on campus. So I'm especially excited to be able to talk today about a topic relevant to geriatric psychiatry. And of course, when thinking about exactly what I was going to speak on, there were numerous topics that came to mind, but I ultimately chose to focus on late onset depression because, of course, as a geriatric psychiatrist, I primarily treat depression, and I can imagine that in the seniors clinic, you guys have a large number of patients struggling with depression, and late onset depression is by definition depression that first develops in older age, and it can be really, really challenging to treat. So understanding some of the underlying mechanism and the reasons that make late onset depression difficult to treat has helped me in my own practice. So I'm hoping giving kind of a broader understanding and depth to the diagnosis will help others as well. And in that vein, I tried to make this talk very clinically relevant, but if there are more specifics somebody wants about studies or the information behind some of the data I'm citing, please feel free to reach out and I'd be happy to send that along. I have no disclosures. The objective for my talk includes talking about what defines late onset depression, also knowing what some of the key clinical characteristics of late onset depression is, and also knowing how the diagnosis of late onset depression impacts treatment and outcome in older adults. This is an outline about what I'm going to be speaking about today, and a lot of this will focus around a case that I'll start with, which really gives a good overview as to what late onset depression looks like. And from there, I'll use that as a jumping off point to get into some of the more specifics. So the patient I'm going to talk about was actually somebody who I'm currently treating and have been for the past year. So this is Mrs. A. So she's a 75-year-old retired dispatch worker. She lives at home with her husband. And she was referred to me for psychiatric care due to a diagnosis of depression about a year ago. And she's continued to have significant mood symptoms despite several antidepressant trials, as well as brief psychotherapy. Her past medical history is notable for hypertension, which is intermittently poorly controlled, type 2 diabetes, which is also poorly controlled, with an average hemoglobin A1C of 9. She had a prior TIA just before her depressive symptoms started. So that occurred in 2020. And she also struggles with chronic pain due to postherpetic neuralgia. And she came to the appointment today with her husband, who helped provide the history. Her chief complaint is, I don't care about anything. And what she described to me was significant difficulties with apathy and anhedonia. She describes really a loss of interest and drive to engage in previous activities. Before a year or two ago, she said she liked to garden, go to her grandchildren's games. And now she says it's really hard to get motivated to do any of those things. She describes feeling slowed down, tired, and as a result, she is spending increasingly more time at home and doesn't get out very often. She didn't spontaneously endorse any mood symptoms, but when I asked her specifically, she said, yeah, her mood is low, but it's not to the point that she's so dysphoric that she's constantly tearful or anxious. She is having difficulties with sleep. She reports insomnia. She said even though she's spending about 15 hours a day in bed, her sleep is still really fragmented, and she has a hard time getting to sleep and falling asleep. Her appetite is reduced. Food just doesn't taste as good, and she's lost 10 pounds over the past 6 months when I looked at data in her chart. And she does say that she feels hopeless. Since she hasn't been doing much, she says, what's kind of the point in living? I'd be fine if I died, but she denied any active suicidal thoughts. Her husband was able to provide some collateral, and he really confirms what the patient says, describing there's been a noticeable change in his wife over the past year. And he reiterates that she really doesn't want to do anything, that it's challenging for them to get her to engage in family things. He also notes that she can't make any kind of decisions. And this was also really evident in our appointment, especially towards the end, surrounding discussions about medications and treatment options going forward. When asked about mood symptoms, it was also, not the first thing that he endorsed in terms of issues that have been going on, but he does say that she's been more irritable and things upset her more than previously. He also notes that it seems at times that she lacks insight into her depression, that she'll go days without taking her medications, and it's also harder to get her to attend appointments, and he really has to push her even for today's appointment. I asked him about cognition as well, and he said that yes, he has noticed some changes, but they're more on the mild side. She's still doing all of her ADLs. She is needing more assistance with things like paying bills, cooking, managing her medications, but it's unclear to him if that is due to cognitive changes versus some of the apathy that she's experiencing. Her psychiatric history was really unremarkable. She denied any previous difficulties prior to the past year with any depression, including prior postpartum episodes. And I always ask my female patients who have had children about this in particular, because this is when women are most vulnerable to prior depressive episodes. But she had 2 kids and denied having any mood problems afterwards. So as a result, she never had any previous psychiatric treatment. However, during this episode, she had been tried on a number of medications, typical kind of first line SSRIs, sertraline, escitalopram, paroxetine, and she tolerated all of them and was at a therapeutic dose for several weeks, but failed to receive any benefit. When she came to me, she was on duloxetine, given her comorbid pain at 90 milligrams, and was tolerating that without issues, but was also not experiencing any benefit. She had been on some other medications for augmentation at other points, trazodone for sleep, Buspar, neither of which she was on at the time I saw her. In conjunction with medications, she had done 8 sessions of CBT-based psychotherapy and also did not get significant benefit from that. There were no substance issues, current or previous, and also notably no family history of depression, anxiety, or suicide. Her mental status, she in the office did seem slowed. Her movements were slowed, her responses were slowed. Her affect was mood congruent. She did seem restricted and dysphoric, but really, no anxiety present. She wasn't tearful. She was oriented ×3, but did seem to have some short-term memory difficulties when speaking with me, including difficulties remembering medication names, dosages, timeline of symptoms. Fortunately, she came to me with a pretty thorough previous medical workup for her symptoms. So she had had all the typical labs done to rule out medical causes for depression. Also, reversible cognitive disorder labs had been completed and were all unremarkable. In the context of her TIA, she had also had a head CT done, which didn't show any significant findings, but did show a moderate burden of chronic microvascular changes and also generalized atrophy. She had a sleep study done in 2019, which showed moderate sleep apnea, but the patient said that she regularly uses her CPAP. This was the results of her MOCA. Her clock, it was not done in a separate paper, so I don't have that. But as you guys can see, she scored 21 out of 30, so there was definite dysfunction. And looking at where, a lot of it was centered around the executive dysfunction. Her cube, she had some difficulties with the hands of the clock. Her trails were pretty good, but not perfect. She also had some difficulties with language, as well as delayed recall. So definitely some notable changes in those 3 specific regions. So when I think about formulating this case, what are some of the key things that stand out to me? So first, this is a woman in her late 70s, and she's coming in with 1 year of new depressive symptoms, and she has no prior history, even during postpartum phase when she would have been most vulnerable in the past. And also she has no genetic loading. So this is not somebody with a strong family history of depression. And she's really functioning poorly due to the apathy and aid motivation that she's experiencing. And despite only having depression for the past year, she's already pretty treatment refractory. She's failed 4 medications. She's had some augmentation strategies, but really hasn't gotten better whatsoever. And her depressive symptoms occurred shortly after she had a TIA. And this is also in the context that she has a number of other vascular risk factors, hypertension, poorly controlled diabetes, and she has other medical problems, most notably difficulties with chronic pain. I think the other important piece is there are cognitive changes that seem to have emerged kind of around the same time as her depression, with that MOCA score of a 21 out of 30, and then also the husband's report that she seems to have some poor insight into her depression and isn't really taking her medications consistently. So if we think about this case purely just from a DSM perspective, this woman would get diagnosed with a major depressive disorder, single episode of moderate severity, and also likely an unspecified cognitive disorder given those changes that we saw. But I really think that speaks to some of the DSM limitations of the DSM, because that MDD diagnosis would be pretty much the same as, or would be the same as if a 16-year-old who was treatment naive with 3 months of depressive symptoms came in, they would also get that same diagnosis. And then the question too is a patient who, of a very similar age, who has had 3 lifetime prior depressive episodes, now with 2 months of recurrence, would also get an MDD diagnosis. The single episode specifier would be changed to recurrent, but at the same time, the patient with prior depressive episodes would be in the same category as our patient with new onset depressive symptoms. And are these two cases actually the same? And that, is a lot about what I'll talk about when we think about early onset versus late onset depression in geriatric patients, because depression is heterogeneous and these two patients are actually two separate entities. And that has important implications for treatment that I'll get into and discuss. So when we think about geriatric depression, depression in these patients falls into two separate categories. So one is late onset depression, and this is where a first episode of depression happens later in life. The age cutoff varies depending on which study you look at, but typically thought to be 60 to 65. And this is in contrast to geriatric patients who experience early onset depression. And so this is where their first age of 60 or 65, depending on where you put the cutoff. And then any depressive episodes that happen later on, that is considered a recurrence. And the next question that this brings up is, does this actually matter? Are there true clinical implications between the two diagnoses? And also, should we be distinguishing these diagnoses in patients? And the answer is actually yes. And this has been a big source of study and research investigation in geriatric depression, that there are key differences between late onset and early onset depression in geriatric patients. The presentation and prominent presenting symptoms are different. There are thought to be different neurobiological underpinnings. Expectation regarding treatment response and symptom recurrence is also different, as are some of the later associated diagnoses and outcomes. So when we think about the symptom differences between late onset and early onset, they both have the same core depression features. And so, I listed out the DSM-5 diagnoses for a major depressive episode. And so, these things are the same. And so you certainly see these across both types of depression. But what we see in late onset depression is there are different features that predominate. And some of the literature talks about late onset depression as a depression executive dysfunction syndrome, which basically means that in late onset depression, individuals' frontal lobes, because of the depression, are not functioning optimally. And this is where it's thought that a lot of the cognitive changes that we see are coming from. And if you do studies or even, kind of in-office testing, these patients do have cognitive changes and abnormal performance in various areas. This is also where the anhedonia comes. And so it's really common that these patients experience that kind of apathy, amotivation. And that tends to be more prominent, well, certainly goes along with some of the mood changes, that anhedonia is really significant. There are also a lot of neurovegetative symptoms that emerge as a result. And so this is where we see with geriatric patients, the reduced appetite, the weight loss, some of the psychomotor retardation, so that just kind of generalized slowing. Patients describe feeling kind of weighted down. And also the other important feature is that there's really pronounced disability. So the symptoms are leading to significant functional impairment. And so how does this manifest clinically? So how do patients with late onset depression look when they come into the clinic? like I mentioned, they really describe a lot of difficulties with apathy. And yes, they do describe like low mood or irritability, but when you look at them, they're not typically the most dysphoric, depressed looking patients. Despite this, they have a very large degree of functional impairment. And so that really exceeds what would be expected given their level of depression on presentation. And so, these are the patients, like the patient in our case, who's not leaving the house, not really able to do much at all at home. And then the other prominent feature that you see is these cognitive changes. They have far more difficulties with problem solving, indecisiveness. They can be very overwhelmed with new situations, and those can be kind of very anxiety inducing. Like for instance, right now I'm treating a pilot who, or I should say a retired pilot who previously used to, fly all over the world on a regular basis. He's now struggling with depressive symptoms at first onset episode later in life. And he now finds even traveling to where his kids live, which he's been doing for 20 years, completely overwhelming, because any new situation is very hard to navigate and anxiety producing. And so oftentimes you may find these patients start to avoid things. They avoid travel, they avoid driving, anything with kind of a level of unpredictability. Previous tasks that used to be no problem become increasingly difficult. And another thing that is common in these patients when you see them is they have less insight into their depression, and also their need for treatment. So a lot of times it's family that's very concerned about the depression or bringing them in for treatment. So this is a nice table that distinguishes some of the features in geriatric patients with early onset versus late onset. And some of the things that I have yet to mention is in early onset, it's much more common that patients have a family psychiatric history versus in late onset that's usually absent. And then also obviously past psychiatric history, early onset, that's kind of a defining feature versus late onset, it's absent. And then also medical comorbidity. There's usually a far greater degree of medical comorbidity in the late onset versus early onset patients. So how does this concept of late onset depression relate to our case? So, she obviously fits the criteria because this is her first episode of depression. She has no history and it's occurring after the age of 65. She's coming in with all of the core features that we commonly see. So really that kind of apathy syndrome. And while she has depressed mood, it's less prominent and there's less intense suicidal ideation. There's greater than expected functional impairment given her degree of depression. She also has cognitive changes, and this depression occurred in the context of medical issues. She specifically, she had the TIA shortly before the depression started, and she also has a number of vascular risk factors and difficulties with chronic pain. And the fact that our patient has vascular risk factors, prior TIA, and also medical issues, this is very characteristic of late onset depression. This late onset depression really appears to develop primarily in the context of medical or neurologic disease. So I think we're all very familiar with the association between heart disease and stroke and depression, and also a high burden of total medical illness can predispose patients to developing late onset depression. And so knowing this kind of raises the suspicion that potentially late onset depression is related to an underlying vascular pathology. or also chronic inflammation and stress overload due to the high burden of medical illness. So in thinking about this vascular depression hypothesis, this is supported by the fact that there's a lot of comorbidity between depression, vascular disease, and vascular risk factors. Like I mentioned, post-stroke depression, there's also a strong link between uncontrolled diabetes and depression. And so what's the mechanism that links vascular disease with depression? And it's really thought to be due to small vessel disease. So there's a gradual accumulation of these microvascular changes, and that causes, regions basically of neuronal and axonal death. And once at a certain point, when these accumulate, there's a tipping point. And when these are in the areas of the brain that control mood, this then emerges with specific clinical manifestations, such as depression. And we actually do see this. So when people have investigated the amount or the burden of hyperintensities in the MRIs of patients with late onset depression, they've been shown to have a greater burden compared to matched controls without depression, and even those with early onset depression. And a lot of the hyperintensities are seen in three regions: periventricular, also in the deep white matter, and then the deep gray matter. So, here's a picture kind of outlining, here's an MRI of subcortical disease in late in life depression. And you can see one is pointing to those periventricular hyperintensities, two is some of the deep matter, the deep white matter, and then three is the gray matter. And so these are the things, these are the areas that are most affected that then predispose people to late onset depression. So beyond these brain changes, there's also the hypothesis I mentioned about chronic inflammation and stress overload. And this figure kind of talks about the association between depression and medical illness. So as we age, we develop more chronic medical issues, which causes more inflammation. We then have more disability, and those two things combined contribute to depression. And then depression has the potential to predispose people to more medical issues. And so it's this kind of vicious cycle where the medical issues and depression play off each other and exacerbate each other. And this slide kind of just further discusses that, but also brings up the issue that late onset depression is a risk factor for dementia. And it makes a lot of sense just thinking about some of the underlying neurologic changes that we see in terms of the vascular insults, and then also the other chronic medical illnesses like hypertension, uncontrolled diabetes, that all predispose patients to dementia as well. And we all know the high rates of depression within dementia. So over the course of somebody being diagnosed with Alzheimer's, over their treatment course, 30 to 50% of these patients will be diagnosed with depression. It's up to 50% in vascular dementia, and the same with Lewy body. And the interesting thing is that depression is especially common in the prodromal phase of illness. And this is a slide that I really like. And this basically talks about what are the behavioral and psychiatric symptoms that we see in patients diagnosed with dementia and at what point in the in their treatment course. And so on the one axis, there's frequency, and the other, it's the months either before or after diagnosis. And so you can see at about 20 months before diagnosis, 50% of patients are showing symptoms of depression. And then as you kind of get closer, you see at about 10 months, there's anxiety, and then right around the time of diagnosis, there's further mood changes. And this is really what I see in clinical practice. Patients with no psychiatric history come in with a first onset of sometimes very severe, very debilitating depression. And when I see them, I'm always kind of waiting for the other shoe to drop, because I know the association with late onset depression and dementia. And so oftentimes what I see is we'll work for 1 to 2 years to treat the depression. And over that time, it becomes increasingly clear that there are worsening cognitive symptoms and an emerging underlying cognitive disorder. And so, when I see patients with late onset depression, I am kind of always looking and screening for cognitive changes and further decline, especially as we get close to that kind of 20-month mark, given studies that show that that's from the time of first onset depression to the time of dementia. That's kind of the common time frame. And so another kind of important thing when I consider some of the underlying neurologic causes of late onset depression, a lot of it surrounds, risk factor modification. So controlling diabetes, hypertension, vascular risk factors, that's such an important part. And I think a lot of patients think about those types of things more in terms of cardiac health, and I do think increasingly in terms of brain health, but it's another consideration that also like mood health and decreasing your risk of depression later in life really goes along with those things as well. And it's a really important part of patients' treatment to help prevent late onset depression. So I'm going to go back to the case for a second and bring up another important clinical point that I mentioned earlier, which is that this patient, despite 1 year of symptoms, is already quite treatment resistant. She's been tried on 4 antidepressants, had psychotherapy, and really has had no response. And that has continued during my treatment with her, even after that first appointment. And so that brings up the question, is treatment resistance a typical symptom of late onset depression? And unfortunately, it very much is. So late onset depression patients are more challenging to treat, especially in comparison to patients who have had previous episodes. There's a higher likelihood of treatment resistance. And there was a study done on late onset depression in the 1980s, and kind of current literature still suggests that this holds true, that there's kind of a rule of thirds, which is 1/3 of these patients will reach remission, 1/3 will continue to have the same degree of symptoms, and the last third will experience worsening of their depression. So when we think about treatment outcomes with late onset depression, unfortunately, symptom persistence is the norm. And because a lot of these patients have profound functional impairment, that typically continues to some degree. And the patients who reach remission, unfortunately, they are at high risk of recurrence. So in those that reach remission, 60 to 70% experience another episode, and 40 experience multiple recurrences. So having a first episode of late onset depression really does put you at risk going forward of having either persistent symptoms or recurrence, even if you are able to reach remission. And in thinking about this, I do wonder if part of the difficulties treating these symptoms and also maintaining remission is because of a lot of that underlying neuronal dysfunction. That we can certainly, work to mediate some of the symptoms, but we're also kind of fighting against some of the underlying vascular and inflammatory processes that antidepressants don't treat. And since those are less prominent in geriatric patients with early onset depression, it can be easier to improve their symptoms and get them to a point where they're more functional. This is a nice table that talks about the outcomes in early onset versus late onset depression. And it really just kind of summarizes what I mentioned, that with late onset, you do expect poor treatment response with more chronic episodes and more residual symptoms with a higher risk of relapse. So I will touch briefly on some of the treatment considerations in late onset depression. And really, all our currently available antidepressants are equally efficacious. There's not one that has shown to be more effective than others. And due to tolerability and safety profile, SSRIs are certainly considered first-line therapy. And I often tailor my treatment depending on symptoms that patients are presenting with and which antidepressant medications might alleviate those, knowing that all of them are about equally efficacious in terms of treating the depression. Unfortunately, antidepressant response in late onset depression is pretty variable. And interestingly, there have been some studies showing that the oldest age groups have a less robust and also poorly sustained response. So they tend to do the worse with antidepressant medications. The other thing that's challenging in older adults is that antidepressants do take longer to work. So in younger patients, we typically counsel them, 6 to 8 weeks, you might start to feel an effect. That is more 10 to 12 in geriatric patients. So we have to wait longer, and also the likelihood of a response is lower. There are some new antidepressants that have come on the market over the past year. The data on them in terms of late onset depression is really lacking, but there's nothing to suggest that they're more efficacious or should be used before kind of previous older antidepressant medications. This is a table, and I won't go into too much detail because I know you guys are all very familiar with antidepressants. I will just mention a couple of things when I think about treatment of late onset depression. In terms of SSRIs, I typically pick escitalopram, given the lower drug-drug interactions, also the less likelihood to induce early activation. So if a patient is predisposed to anxiety, somatic symptoms, escitalopram is less activating and less likely to cause that compared to some of the more activating antidepressants, I think in particular Prozac. Of course, with escitalopram, you do still deal with the QT prolongation. I also tend to choose sertraline. However, the issue with that is it's the most likely out of the SSRIs to cause GI upset. So depending on the patient, I may not choose that one. And I pretty much never prescribe Paxil just due to its short half-life and also anticholinergic side effects. SSRIs are second line for late onset depression. I tend to consistently pick venlafaxine. A lot of the studies in treatment-resistant depression in older adults, they use venlafaxine. Even though it can be very challenging for patients to come off of it, I do think the data would show that it's more efficacious in in terms of treating kind of treatment refractory depression compared to duloxetine. In terms of some of the atypical antidepressants, I do use a lot of mirtazapine, especially, thinking about targeting some of the low appetite and insomnia that goes along with late onset depression. I find that can be very helpful at alleviating those symptoms. In rare and more treatment refractory cases, I certainly do use TCAs and MAOIs, but reserve those for specific treatment refractory cases where really no other medications have been helpful. I can't talk about late onset depression without talking about electroconvulsive therapy. And those of you that know me also know that this is a very big clinical interest of mine. And I do think a bright spot when we think about the treatment of late onset depression, because electroconvulsive therapy, I don't know how familiar people are with this treatment. It's basically a medically induced seizure. So patients are under general anesthesia. They typically seize for about 30 seconds to a minute. The brain stops the seizure on its own, and patients on average require about 10 to 12 treatments, with treatments being 2 to 3 times a week, with response usually seen after 6 to 8 treatments. So in about 2 weeks of treatment, patients start to get better. And it really is the gold standard in depression in general, but specifically late onset depression when a rapid response is needed. So patients that are not functioning to the point that they're experiencing failure to thrive, if they're suicidal, having psychotic symptoms. And there's a lot of misconceptions about the safety and efficacy of ECT, but there have been numerous large clinical trials and meta-analyses that have consistently shown safety of its use, even in geriatric patients. And with specific medical optimization, it can be the most effective treatment for frail older adults. When I think about rates of response with ECT, so when we think about an antidepressant medication in this patient population, clearly a lot of times the results are lackluster, with oftentimes 20% of patients responding. And so responding meaning 50% reduction in symptoms. When you compare that to ECT, the remission rates, meaning minimal to no depressive symptoms at the end of a treatment course, is usually cited to be around 60 to 80%. So there's a much, much higher, not only response rate, but remission rate in patients receiving electroconvulsive therapy. And I do want to cite one study in particular related to ECT that was done in 2017. And it looked at 110 patients, 55 years and older, with unipolar depression. And actually having late onset depression was a predictor of response. And unlike antidepressant medications, where the older age patients show less response, ECT has consistently been shown to be the opposite. So older age is usually seen as a sign that predicts response and remission with ECT. And so in this particular study, response rate overall in the whole population of 110 patients was 78.2%. And in patients with late onset depression, that was 86.9 compared to 67.3 in the early onset population. So, while certainly medications, in particular antidepressants, have variable efficacy, ECT has really been shown to be helpful and safe in cases of refractory or severe late onset depression. I'll briefly touch on some future treatment considerations. One that I think is pretty exciting in psychiatry is transcranial magnetic stimulation, or TMS. And this is basically an in-office procedure that uses magnets to create an electrical field that stimulates areas of the brain thought to be hypoactive in depression. In particular, it targets the left dorsolateral prefrontal cortex. And so it sends pulses that are excitatory, and it has been shown to be helpful for depression not responsive to medications, not to the same degree as ECT, but slightly more effective than medications. And it has no side effects, unlike medications. Unfortunately, so far there's been pretty variable evidence in late onset depression or even geriatric depression in general. And that's thought partly due to some of the just general brain atrophy that occurs in older adults. So it's really harder to stimulate the areas of the brain that the coil is targeting. But there are some ongoing studies about threshold of treatment and whether this might be another option for patients struggling with late onset depression. I'll briefly mention ketamine as well, which is, I think, been the new hot thing in psychiatry the past couple of years, which is an NMDA antagonist. Specifically, there's like an intranasal form called S-ketamine that's FDA approved for treatment-resistant depression. And currently there are some case studies showing efficacy in late onset depression, but no current large trials. I think there's some hesitancy just given some of the potential side effects of ketamine. However, the intranasal form is generally safe and given at a very low dose. So just some take-home points to kind of wrap up the presentation. Late onset depression is a unique clinical entity in geriatric patients, especially when we compare it to early onset, where patients have had episodes of depression prior to the age of 65. The two share the same core features of depression, but late onset really can be predominated by apathy, cognitive changes, neurovegetative symptoms, and also a more predominance of lack of insight. And it's thought to potentially be related to underlying vascular changes or increased burden of medical illness that's seen as we age. It's very challenging to treat with a higher degree of recurrence and symptom persistence. The antidepressant response is variable, with no one antidepressant showing more efficacy. ECT is certainly the gold standard for cases that are severe or where immediate response is needed. And actually the presence of late onset depression has been shown to be a positive predictor in response. And I think the other important clinical thing is really in these patients to watch for dementia, which may emerge 1 to 2 years after diagnosis. All right, I'll turn it over for any questions or comments.
Yeah, great. Thank you so much. That was wonderful. So a couple of questions coming in, 2 questions related to access to and availability of ECT at university.
Yes, actively working on it. I am really trying to get an ECT program going, and it's unfortunately been a little bit slower going than I expected, but potentially spring. But it is definitely in the works.
Another question related to medications. So given the longer time to effect that you cited, so more like 10 to 12 weeks in older adults, the question is, what interval do you suggest for dose up titration?
And so I think that often is really a case-by-case basis. So I certainly don't wait the full 10 to 12 weeks to adjust dose, especially if somebody is struggling with significant symptoms. And a part of that, my rationale is, let's say I'm treating somebody who has a lot of difficulties with sleep or low appetite, and I'm starting Remeron. While some of the antidepressant effects may take 10 to 12 weeks, my expectation for some of the other kind of positive side effects that the medication has in terms of inducing sleep or inducing appetite would start earlier. So, I do, and I think it also depends on the setting. When I think about outpatient treatment in particular, I probably do wait 4 weeks, but I certainly do not always wait the full 10 to 12 weeks for effect to change the dose.
Another question coming in is whether there are data on what percentage of older adults with late onset depression do go on to develop dementia.
Yeah, and I can look at, I can't recall the specific number off the top of my head, but it is a large number. It probably in the 40 to 50% range. So it is a significant risk factor for subsequently developing dementia.
And how about whether, do you use pharmacogenetic testing to help find possibly more useful agents?
So it's a great question and could be kind of a topic of a whole other grand rounds. So when I think about the doing the pharmacogenetic testing, what that really tells us is how a patient metabolizes medication, right? So it basically says whether you're a rapid metabolizer, a slow metabolizer, or a normal metabolizer. And so it doesn't really give us any insight into what treatment response will be. So I do think sometimes it can provide some benefit in terms of patients with a lot of anxiety who tend to have a lot of side effects for medications. There is oftentimes a high cost and it's not always covered by insurance, but that may kind of clue you in as to which medications and kind of what doses of the medications might be most appropriate. But unfortunately, it in no way tells us about the clinical benefit in terms of depression of medications. So in respect to kind of treatment-resistant depression, where you're trying a lot of things to see if you can get a treatment response with medications, unfortunately, the testing doesn't really guide us in that aspect.
And a question from Dr. Farrow, thoughts on the application and outcomes of behavioral activation interventions on late onset depression?
I'm all about it. I think that those type of things are extremely important. I think that there's no side effects, which unfortunately a lot of medications and other things that we prescribe to patients do. And I think the behavior activation is so key in terms of also kind of preserving function. And if you don't use it, you lose it. So I'm certainly a very big proponent of behavioral activation.
And then another question on whether widespread use of statins might change the incidence of late onset depression if vascular issues improve.
Absolutely. I mean, I think, when I think about late onset depression and also dementia, I think there's always this rush to kind of think about what new treatments might be found to reverse symptoms or preserve cognitive function once it emerges. But I do think so much more of the focus does need to be on prevention in terms of vascular risk factors, hypertension. And of course, there are always going to be patients because of underlying, genetic predisposition with depression, maybe prior stressful incidences where they're going to develop depression. But I do think modifying vascular risk factors will subsequently reduce the rate of late onset depression. And then I think the challenging part is once you have late onset depression, it's extremely challenging to treat and also get those patients in sustained remission. So I do think prevention side is important.
Any other questions or comments? In here. Okay. Well, we will go ahead and, one more. Any specific exercise-based programs you would recommend for late onset depression?
I also think that that's probably really patient dependent. I think exercise is also extremely important. So based on their physical capacity, depending on kind of where they are with medical comorbidities and cognitive function, but certainly meeting as much as possible kind of the recommendation for 30 minutes of exercise several times a week is really important as well. And I think that could also help with some of the vascular risk factors.
Okay. All right. Well, thank you once again for a really wonderful presentation. This was fantastic. And thanks everyone for joining in, and have a good rest of your day. Thanks.
Thanks so much for having me.